It is Monday morning. Your front desk opens the prior authorization queue, and 35 TRICARE authorizations are pending. Peer-to-peer reviews are already colliding with the clinical schedule, and the week has barely started. If your practice serves military families, this is a recurring operating condition. At the end of fiscal year 2024, there were 9.4 million beneficiaries eligible for Department of Defense healthcare benefits spread across the system. The administrative weight of managing care for this population is measurable. According to the 2024 AMA Prior Authorization Physician Survey, physicians and their staff handle an average of 39 prior authorization requests per physician every week. This bar chart compares a standard 40-hour work week to the specific administrative toll of those requests. As you can see, they consume 13 hours of physician and staff time every single week. Despite that massive time investment, 31% of physicians report their PA requests are often or always denied right out of the gate. This pie chart illustrates what happens when those initial rejections are pushed back on. 81.7% of appealed TRICARE denials are eventually overturned, proving that the vast majority of initial denials are workflow failures, not clinical ones. The friction on the clinical side is severe, with 89% of physicians reporting that the prior authorization process significantly increases their burnout. The consequences on the patient side are even clearer. 82% of patients commonly abandon their recommended course of treatment simply because of these administrative delays. By continuing to manage TRICARE PAs through standard manual workflows, practices are forced to trade vital patient care hours for administrative overhead, while simultaneously leaving legitimately earned revenue on the table. The root cause of these high denial rates comes down to the structure of the program itself. TRICARE is not a single payer with a single set of rules. Staff must accurately identify and navigate the distinct requirements for TRICARE Prime, Select, TRICARE for Life, Reserve Select, and TRICARE Young Adult. This map of the United States breaks down the regional fragmentation. Humana Military handles the East region, TriWest manages the West, and Express Scripts operates across the board for pharmacy benefits. This creates a portal problem. Staff must constantly switch between completely different submission interfaces and upload requirements based on the patient's specific region and plan. It also creates a documentation trap. Practices frequently submit complete records for specialty drugs, receive a denial citing insufficient evidence, and find themselves trapped in a loop of resubmitting the exact same paperwork. When cases escalate, the peer-to-peer problem emerges. Physician calls are routinely lost on pure technicalities because the correct chart materials and prior therapy timelines were not systematically prepared in advance of the call. Expecting general front desk staff, who already face normal industry turnover rates, to successfully navigate this multi-portal, multi-policy labyrinth without highly specialized training is an operational miscalculation. There is a strategic alternative to this manual friction. A growing number of practices are outsourcing the entire workflow to specialized teams equipped with AI infrastructure, like Staffingly. The workflow starts with an AI agent accessing the practice's EMR via a secure VPN to automatically extract the order, clinical notes, and demographics. In this workflow decision tree, the reasoning engine matches extracted patient data against current TRICARE policy, drafting a cited medical necessity narrative. Google Vertex AI automatically classifies supporting evidence into categories. Finally, the orchestration layer routes the package instantly to the correct payer portal. Before any of this is submitted, an AAPC credentialed specialist reviews the AI-generated draft to guarantee clinical accuracy. The human oversight is built into the system. If a peer-to-peer review is required, the system generates a structured briefing and delivers it to the treating physician 30 minutes prior to the call. While all of this happens, a parallel process called InsuVerify runs live eligibility checks at intake to guarantee the TRICARE plan type is accurate before the submission ever begins. Combining automated data extraction with credentialed human oversight completely eliminates manual chart hunting and prevents plan type routing errors before they happen. To understand why practices are making the shift, we have to compare the hard financial costs of the status quo against the outsourced alternative. The fully loaded financial burden of an in-house PA coordinator ranges from $55,000 to $84,000 annually once you factor in salary, taxes, and turnover. This comparison matrix shows the contrast. Against that in-house expense, the Staffingly outsourced tier costs $399 per week, drastically reducing overhead while maintaining a fully scalable department. Because the infrastructure is already built, this outsourced model scales instantly without the usual hiring delays, going live within 5 to 10 days. There is also a new regulatory urgency to fixing this process. On January 1, 2026, the CMS 0057F regulations went into effect. This CMS mandate requires impacted payers to deliver standard PA decisions within 7 calendar days and expedited decisions within 72 hours. It also requires them to provide specific reasons for all denials. Because payers are now held to these strict new timelines, practices that upgrade their first-pass documentation quality today will secure significantly faster approvals. Keep in mind that 81.7% overturn rate on appeals. Every denial that sits unworked in your queue is effectively abandoned practice revenue. For practices serving military families, the math is straightforward. Trading $399 a week for a specialized AI-driven service to eliminate a massive overhead expense, reclaim 13 hours of physician time, and systematically recover your lost revenue.